Good morning.
Good morning.
This is Dr. Noor, one of the children's doctor in this hospital. After introducing myself to mother of Jack and Jack, I will wash my hands and take permission for examination. And I will first look at the general look of the Jack, if he is in distress and whether he well communicating, and for his weight, height, and head circumference.
He's small for his age, and in the picture you can see for any unusual features, and he's not communicating well with you.
Okay, not in distress.
But
So
not.
then I will go for, there are some unusual facial features on his face, like epicanthic folds, depressed nasal bridge, and thick lips with long philtrum. And also some spacing between the teeth I can see in the universal Q, and small chin as well. Eyes I cannot describe. It's not clear for me. Then I want to see if he is attached to any devices and anything in the surrounding.
No, there is nothing in the surrounding.
Okay. Then I will go for his hand to look for pallor, cyanosis, clubbing, and any stigmata of infective endocarditis like splinter hemorrhage, Osler's nodes, Janeway's lesions.
Nothing is there.
Okay, then I will check his pulse for rate, rhythm, volume, character, radial pulse. And also I will check both the sides to see if there is any radio-radial delay, and also the femoral pulses to see any radio-femoral delay.
There is no radio-radial delay and no radio-femoral delay, and the pulse is normal volume with normal character, and the rate is about 90 per minute.
Okay, then I will examine his face, for any pallor in the eyes and the color of the iris and any changes in the iris, if you can come.
Yes, in the eyes you did not find anything.
Okay,
No pillar, no jaundice.
I will ask him to, I will ask Jack to open his mouth to see for any high arched palate and dental hygiene and pallor and cyanosis.
Yes, dental hygiene is little bit poor, but other things there is nothing.
Okay, then I will check the neck for any visible pulsations and any thrills also.
How will you check the thrill? You are doing the inspection.
I will, okay, any visible pulsations?
No.
Just pause the time 1 minute. I have something.
Okay.
Okay,
Dr.
continue.
Yasser, you are taking.
Yeah,
Dr.
continue.
Yasser is.
Yeah.
Continue
Okay.
the time. So I will check for any visible pulsations in the neck. Then I will go for inspection of the chest. I will make the child to lie down on the bed and look from the side if there are any deformities. And also I will look for any scars on the chest and also in the side of the chest by asking the child to lift his axilla.
Yeah, there is no scar, and there is no chest deformities.
No scars, no deformities. Okay, then I will proceed for palpation. I will put both my hands on the child's chest to locate for the apex beat. After feeling the thirst in one position, I will keep my hand there to locate it. Where is the apex beat?
Yes, apex beat is in the fifth intercostal space in the mid-clavicular line.
Left side.
Yes, left side.
Okay, then I will warm my hands and start palpating for the thrill in all the 4 areas: mitral, aortic, pulmonary, and tricuspid area, if I can feel any thrill.
Yes, you can feel the thrill in the left upper sternal edge.
Left upper sternal edge. Okay. Okay. Then I will keep the heel of my hand in the left lower sternal edge to check for the parasternal heave.
No,
Okay.
there is
Mm.
no there is a parasternal heave. Yes.
Okay. Then I will proceed with auscultation of all the 4 areas of the chest, that is again mitral, tricuspid, aortic, and pulmonary, to listen for the first and second heart sound, and if there are any murmurs.
What else you want to see? You want to auscultate apart from the murmur?
Apart from that, I want to auscultate the back for lungs, basal
No,
crepitations.
I mean to say you want to check for the first and second heart sound as well.
Yes, I want to check the first and second heart sound and murmurs, and also the radiation of murmurs.
There is systolic
6
murmur,
minutes finished.
ejection systolic murmur
Hmm.
on the left side, left upper sternal edge, and the first and second heart sound is normal, but there is widely split second heart sound.
Okay, widely split. And okay, is the second heart sound soft? Also, I would like to check. Then I want to, the lung bases are clear.
Yes.
And I will check for hepatomegaly, abdomen for hepatomegaly and lower limb edema. Then
Yes, there is no.
okay, in order to complete my examination, I would like to do the 4-limb blood pressure, 4-limb oxygen saturations, and to check for any femoral scars, and also to take the detailed history and complete detailed history of the child and review his previous records, and weight, height, and plot him on the appropriate growth charts.
Okay.
So today I examined Jack. He's an 8-year-old boy who is not well communicating, small for his age. He has no scars or no deformities. On examination, there is a thrill palpable in the upper left sternal edge, and also a murmur, ejection systolic murmur in the upper left sternal edge radiating to the back, with no stigmata of infective endocarditis and no features of heart failure. With these findings, this child is a syndromic child, most probably going with Williams syndrome with a pulmonary stenosis.
Okay. So, what may be the features of Williams syndrome?
The features in the heart, you mean, or general?
No, physical features. Physical features.
Physical features.
Phenotypically, how they are.
Yeah, phenotypically, they have unusual features in their face, like epicanthic folds, depressed nasal bridge, long philtrum, broad, wide smile. Also, they may have with wide spaced teeth, and sometimes bossing of the forehead can be seen, and blue eyes, stellate iris can also be seen in these children.
Okay, very good.
3 minutes finished.
So, no
3
problem.
minutes finished.
Okay,
no problem. So, how will you confirm your diagnosis?
For to confirm it as an Williams syndrome, I will do the genetic testing of the child. And for the heart, for the confirmation of his heart problem, I would like to do the echocardiography to check if this child has pulmonary stenosis or not.
Okay, what else you would like to do?
So I want to do the investigations like ECG, chest X-ray, echocardiography.
Okay, what is ECG? What can you will see?
Yeah, ECG I can see in severe cases right ventricular hypertrophic features like tall R waves and tall P waves as well, and right axis deviation.
Very good. tall P wave and tall R wave in V1 and V2.
V1 and V2, and
So what will be in the chest X-ray?
chest X-ray, we can see prominent right ventricle can be seen with like the prominent right ventricle, and also the oligemic lungs can be seen, and
Okay, great.
sometimes if there is post-stenotic dilatation, we can see the prominent pulmonary artery as well, post-stenotic dilatation.
Okay, great. So what they may have problems in the neonatal period?
Yeah, in the neonatal period, they may have problems of hypercalcemia that has to be
Great.
treated, and also they may have feeding problems.
Yes, great. So what is the indication of surgery here?
Surgery, if we have to, by the echocardiography, the pressure gradient across the valve and is checked, and also the right ventricle. If the pressure gradient across the valve is more than 40 mm of Hg and the patient is symptomatic, and also if the right ventricular pressure is more than 60 mm of Hg, is an indication for surgery.
Okay, what are options for the surgery?
Surgery, we have balloon valvoplasty, percutaneous balloon valvoplasty. And then in some cases, if this is not successful, we can do pulmonary valve implantation as well.
Okay. Okay, that's good. You have done very nicely. Sorry, I have changed for you little
No
bit.
problem. Good, you changed. I was thinking I shouldn't have told you. You shouldn't have sent me this, and I wanted some change only. Good to change.
No. Why I have changed? Actually, I don't know you are the candidate. So I was thinking the candidate is Dr. Yasser. So Dr. Yasser don't have this picture. So I will keep the same with him. So that, but you have this picture. So I want to change this one for you, especially because I have sent you picture already.
Yeah.
So that's why I've changed.
Yeah. Good. You changed. I had a different experience actually. So it will happen in the exam.
So what
Give
happen
your
in
feedback now.
in the Williams syndrome? Yes, in the Williams syndrome, just to memorize, like there are two cardiac lesions, peripheral pulmonary artery or supravalvular aortic stenosis, SVAS. They are writing like this: SVAS, supravalvular aortic stenosis or peripheral pulmonary artery stenosis. They may have these. Okay, if the child in the Williams syndrome are not has been corrected, so there will be no scar. But if they have been corrected and they have corrected this with the surgery, then they may have mid sternotomy scar. Either if they have corrected through the catheterization, they may don't have any scar, maybe scar in the femoral region, which you have already asked me. So what may be the complications after the correction?
Sometimes balloon valvuloplasty, there can be restenosis or
Yes.
regurgitation.
Yes.
Uh,
So if there is restenosis, then we will have the same picture like you have said already. There may be ejection systolic murmur still will be there, and there may be ejection click. And if they have incompetence, so then will be a mid diastolic murmur or early diastolic murmur. Sometimes they may have, and that will be at the same area. Okay. So we in the examination, okay, time no problem, you will cover it time, the no problem. You did not ask me is it radiating to back or not. That should be asked. Okay, one thing. And I think whenever we are doing the epics, we are checking the epics, we should tell about I would like to check the character of the epics as well, so
yeah.
that will give you
Yes,
some clue.
you're right. You're right.
Yes, and these two things which I was thinking.
But
was lacking.
for the radiation, I asked you, maybe you did not. How I asked you? No, I did not. I asked you like, because some examiner told me like this, that when you are asking, ask everything at once to save the time. Like ask about all the 4 areas. Okay.
Maybe you ask like this.
Yeah,
Maybe I
like
will.
that. Yeah, in all the 4 areas, I would like to check S1, S2, first heart sound and second heart sound and murmurs, and any radiation of murmurs. Like this, I told. But
Okay.
maybe you did not hear. And
Yeah, maybe.
lastly, there was some 6 minutes.
And one more thing, whenever this is coming, always ask if there is any other murmur is anywhere. Always ask, because you don't know. Maybe they have done a balloon, this valvoplasty, and there is incompetence also. So you should ask about this one also.
Means
Always.
aortic. I
Yes.
mean, all the.
We we are not specific to tell that there may be diastolic murmur or something, because even consultant, they cannot pick this diastolic murmur. Just to tell that I would like to check, apart from this murmur, is there any murmur anywhere? Okay.
Okay.
Especially if there is aortic stenosis, if you find, because aortic incompetence murmur is not in the aortic areas. This murmur is coming in the left side. So that's why it should be asked always.
Okay. Okay, but
and there are 3 types, this you have studied today. Valvular can be, subvalvular, or supravalvular can be there. Okay. What are other associations with this syndrome, apart from this Williams syndrome?
other associations of pulmonary stenosis, you mean?
1 minute. 1 minute.
Okay.
Yes. So, what are other syndrome which may be associated with pulmonary stenosis?
Noonan syndrome, Alligalis syndrome.
Noonan and Alagille syndrome. So in Alagille syndrome, there is specific peripheral pulmonary artery stenosis. Specific.
Even in Williams,
Yeah, Williams also.
Williams,
they may have supravalvular, they may have peripheral pulmonary artery stenosis. Both can be there.
Okay.
And what else I want to cover? Really, I forgot. Just reach at home. Okay. There was one thing I forgot. I want to tell that one. Yes, when you are demonstrating your, you told me about he's not in failure and he's not in infective endocarditis. Also tell that he's not cyanose and clubbing.
Okay.
You forget that.
Okay.
Yeah. Otherwise, that was fine. Presentation was very, very good. Actually, I will say. So next we can do. No.
Okay, before that, I want to tell some of the points I wrote about pulmonary stenosis. Actually, this pressure gradient across the valve 40, I am not sure. I did not get this, but I got this for sure. That pressure in the right ventricle less than 60. Sorry, pressure in the right ventricle more than 60 is an indication. And not every patient you will go for balloon valvotomy. You will, if they are asymptomatic and the pressure gradient is less than 60, they will be, they will be with continuous follow-up with the cardiologist for ECG and exercise testing and echo. Okay.
Just repeat, please.
I could not listen.
If the patient is there is three things here.
Yeah.
One minute, I will tell you. Okay. There are three things here. If the patient is asymptomatic, okay, and also his pressure is less than 60 mm of Hg in right ventricle, okay, then what you will do, he will just follow, the cardiologist will be following up him up with ECG, echo and exercise ECG. If there are any problems, they will consider for valvotomy or valvuloplasty. Otherwise, they will not. Okay. If they are symptomatic, then definitely you will go. And even though they are asymptomatic and the pressure gradient is more than 60, they will go.
Okay.
Anyways, the pressure more than 60 mm of Hg in right ventricle is the indication for intervention. That is balloon valvuloplasty. Okay. This is the three things. If symptomatic, even if it is less than 60, you will go. If asymptomatic and more than 60, you will go. So the main criteria here is more than 60 in the right ventricle. But I think also one more question was asked about this. Before that, I want to tell you, if they ask about, suppose if they ask about management of critical aortic stenosis, critical pulmonary stenosis in neonate. So what do you tell? General resuscitation. So I will resuscitate the neonate and consider for infusion of prostaglandin. These two things.
Yes.
Okay, before shifting the patient to tertiary center for again balloon dilatation. Okay.
Again, this one, I think they have written this critical stenosis, pulmonary stenosis. There may be a murmur, may not be there.
Yeah.
Yes.
May not. Yeah, you will do echo.
But
because there is stenosis in the child. So when you do the echo, you will get to know the particular diagnosis.
Yeah. But if the murmur is loud and too much, so that will be in the older age. That is also critical.
Okay. You one more picture, because in the exam it was asked, for one of the candidates, when she said echo, okay, tell me the severity of the lesions, like mild, moderate stenosis. When do you grade it as mild, moderate and severe? This was asked. So do you know pulmonary valve?
Yes.
If you know, tell, let me see.
What for grading?
Yeah, grading of pulmonary valve stenosis.
Yeah, this is just told you tell me what to do in the pulmonary stenosis.
No, it is intervention when we do the intervention, right? But they will ask grading of pulmonary. When you tell, like you asked me, right? When I told ECG, you asked me what are the findings in ECG, right?
Yeah. Grading, this one again, I think they are doing according to this gradient. What is the gradient across the wall?
Yeah, do
this
you
is
know
40 to 60, less than 40 is mild, 40 to 60 is moderate, and more than 60 is severe.
Okay, in pulmonary stenosis.
Yes.
Let me see. I have taken one picture. This is from European Society of Cardiology. Here it's written, you see, European Society of Cardiology. So it is, mild, less, we can approximate, as you said, what you said, 40, right?
Less than 40 is mild.
Yeah.
And 40 to 60 is moderate, and more than 60 is severe.
Yeah. This you have to remember. This question they can ask you. This was asked in aortic stenosis case for one candidate. So we will remember like this. As you said, this is easy. So less than 40 is mild. Moderate is 40 to 60, and severe is 60. I will make like this and remember. Yeah, they can ask. So intervention is usually, at least if more than 40, you will start intervention, right?
Yes.
Then 40 mm of Hg, the pressure gradient across the valve. but the pressure in the right ventricle more than 60. This we should know.
Yes.
Yeah, if we tell this much basic, I think it's enough.
Yeah, that's enough.
And
We have
also any patient who is symptomatic will be considered for intervention. One thing, what is the indication for intervention if they ask? Symptomatic.
Symptomatic or gradient, as we told already. If the
More than-
gradient is more asymptomatic, but the gradient is more than 60. And indication for the surgery also if the child is compromising this growth is compromising with that.
Yeah. Okay. So there are some symptoms. So the one is the symptomatic gradient, and in gradient you have to tell two things: right ventricular pressure more than 60, and the pressure gradient around the valve more than 40. Okay. Okay. Sometimes they consider for moderate also to go in as long as they have symptoms.
Okay.
Okay.
Okay. Next we
Next
can do.
we will go for the next case.
Okay, I will try.
Dr. Noor, salam alaikum.
Tell me.
Yeah, what's your differential in this case?
For the murmur, you mean?
Yeah.
For the murmur. Sorry, it is in the left upper sternal edge radiating to back.
There will be two things you can keep it here, like pulmonary flow murmur. That is innocent murmur, but there is a thrill, so very less likely. And the second one, ASD, you can keep it here, ASD as well. ASD is also coming with, but its murmur is not radiating, and there will be fixed splitting of second heart sound.
Here there will be wide splitting, right?
Yeah, in pulmonary stenosis, there will be wide splitting, but not fixed.
And also it will be soft P2. In ASD, I don't think you will have soft P2 and wide split.
Yes.
Yeah, good question. Thank you, Dr. Yasser. Any other questions still, please?
Yeah, how can you differentiate clinically? Although we made a diagnosis of pulmonary stenosis, what's the differential? How can you differentiate between, if I say if he's a case of Noonan syndrome, how can you differentiate from Williams syndrome?
By other features like Noonan syndrome can have some ptosis and short neck, webbed neck, and this in the hands.
Yes.
What we say this?
In the William, there will be stellate iris. Okay. In the eyes of the Noonan syndrome, there are epicanthic folds can be there, antimongoloid slant can be there. There can be ptosis, and what else?
And other features of Turner's we
other
see
features, yeah,
like chest wide space nipples and
webbing of neck,
what is this hand in the hand we see?
Hypoplastic nail.
Hypoplastic nails, cubitus
and
valgus.
Wide carrying angle.
Yeah, cubitus valgus
wide
can
carrying
be there.
angle. Yeah, this word.
Cubitus valgus. Yeah, cubitus valgus.
I hope we will not forget in the exam. Yeah, cubitus valgus.
Because this picture is very similar to the Noonan. Initially, when I saw, he has epicanthic fold, he has downward slant, he has a hypertelorism, just like depressed nasal bridge. He has mycognathia, the same William. So I was shocked to listen your diagnosis. Then I want to compare that picture and to see how can we differentiate in this.
It is also, for me, it was looking like Noonan syndrome, really. But I don't know.
Doctor, but when you took from the Google, was it Noonan's or Williams?
I don't know who has given me this one.
Anyways, in my mind, it was Williams. Another thing I want to ask you something. I told that for the position to examine for cardiovascular is 45 degree, right?
Yes.
Yes.
And you make it flat.
Yeah, then I got a doubt. And like in respiratory examination for inspection, we look from the end of the bed and side of the bed. For cardiovascular, do we look like that or no?
Yeah, yeah, same.
But the child will be in 45-degree.
Yeah, because actually why we have to see the symmetry. You know, when there is some pulmonary hypertension, the left side chest become up, there is some bulge, and to see any deformity, just like Noonan, any excavatum carinatum. So that's the reason we have to see from the foot hand to see the symmetry of the both side of the chest, and then from the lateral side we have also see the symmetry from that.
But in 45-degree position, how will you do this? Will it be clear for you? Lying
Yeah,
position, I agree with you.
yeah, we can do.
Okay. Okay.
And what are the complications of pulmonary stenosis?
So the complication can be they are prone to infective endocarditis.
Okay.
And if it is critical, cyanosis. And they may also have, due to right ventricular outflow factor obstruction, sometimes cyanotic spell in severe cases only.
Then what?
Oh, that's all I know.
Okay, and also remember one thing, in severe pulmonary stenosis, we can get a TR murmur and also raise JVP. Because the backflow, it goes to upward and downward causing heart failure, and upward causing also tricuspid regurgitation, and that one. And if there is any
regurgitation, here will be a flow murmur because of the overfilling of the right ventricle, right?
Again, sorry.
Now, what is happening due to pulmonary stenosis? There is the blood is not going into the pulmonary vein.
Artery. Yeah, artery.
So what happens? There is too much blood in the right ventricle. So it will be.
This is sorry, Dr. Noor. This is Williams syndrome.
Okay.
Sorry, I searched so many pictures. This is Williams syndrome. Confirmed.
Okay, thank you. So
because only one thing that is very difficult, because he has triangular facies, and but in William they have chubby facies, just like having fulfilled of the. So I was confused, Shoya, that.
No. Now I have confirmed on the Google. This is they have written Williams syndrome.
Okay.
So tricuspid regurgitation is due to functional.
Yeah.
But
because blood has only two ways to go.
You tell about the complications. The question you asked me, answer to that. Raise JVP.
Yeah, infective one is infective endocarditis. Second one is the heart failure.
Okay, yeah, I did not tell this, right?
Heart failure, because
they may have right-sided heart failure. They may have TR associated with the increased flow, not increase the filling. Sorry, not flow, increase of filling, and they may have problem with the infective endocarditis.
Okay, so I will write here. I will write down because so that I will not forget. They can ask this. One is complication is infective endocarditis will come in any valvular disease. It's common. We have to remember that. And the
yes, one more thing, raised JVP can be there also.
Raised JVP and tricuspid regurgitation.
Yes.
Okay.
Whenever just memorize, Dr. Noor, you will never forget any chamber, not in the heart. I just will tell you, any chamber from where the water is coming and this chamber is filling too much. So that will cause from where the water is coming, that side, it will cause the problem, because in the front there is blockage. So water cannot go there. But on the back, from where the water is coming, it will give the pressure there. So it will give the pressure, definitely it will try to open that. So I am always memorizing like this.
Yeah.
I'm understanding this.
You told me is infective endocarditis, heart failure, and the findings we can also have of the tricuspid regurgitation and raised JVP. So I forgot to tell, in order to complete my examination, JVP also comes here.
Yes.
So tell once again for CVS case what we will ask in order to complete.
In order to complete, always we'll have to say 4 limb blood pressure, 4 limb saturation, and if available on bedside pulse oximetry. In order to complete, you will tell the JVP, blood pressure, which you have not done in the. So all these 5 things.
Okay.
And if there is any syndromic, and if you are thinking that this syndrome may have some other problems, so that one we included. Like Noonan syndromes, they may have problem with the thyroid, and they may have problem. No, only thyroid, I think. Maybe kidney problems are there, or I don't know. I don't remember this one. Dr. Yasser can tell.
No,
Okay,
there is
But
no
we will
problem.
have to.
later, not now. So
Yeah.
let's do now. Wait for let's collect for Williams. They may have hypothyroidism. Okay, they may have problems in the abdomen like renal artery stenosis and problem in the
Yes.
kidney. So you can tell abdominal. You want to do also abdominal
Yeah,
examination.
if you don't have too much time, just tell that as I am thinking this is the syndrome. So I will, in order to complete, I will check for other associations as well, like this.
Yeah.
Don't tell in that detail.
And see, 4 limb blood pressure, 4 limb oxygen saturation, JVP, femoral scars we should not forget, because if
Yeah.
any percutaneous corrective surgery is done for them, I mean cardiac catheterization.
Yes.
So, femoral scars should not be forgotten.
Yes, definitely.
Okay.
This is also.
And suppose if we were not able to do hepatomegaly, lung auscultation and edema, if we were not able to do, we will mention it here. Okay.
Yes.
Things are very important. Okay. So now let's go to the next case.
Okay, give me the case.
Okay. Did you read today about Williams syndrome, Dr.
Dr. Yasser?
Yeah. I only read today. I was busy, Shoya. I read only pulmonary stenosis and Noonan.
Sorry, I did not listen to you. There was some problem. Tell me. Did you tell anything?
Nothing. You people proceed with the next case.
Yeah, no, I was asking about Williams syndrome. Did you read for Dr. Rohel?
Yeah, I read this.
Today you read from any source which you can tell us?
No. Dr. Noor, I am reading only from this Mrcpch.
Okay, great.
Because every people are saying that Mrcpch more than enough. Every senior is saying don't go away from Mrcpch.
Oh, okay.
So
good.
that's why now I am reading only other things which I know from my previous knowledge when I was doing this PG. So that's I remember. Sometimes I'm telling. Otherwise, I'm not reading from any book. I'm reading only this book.
Okay, good. So now let's go to the next case. Dr. Yasser will give you the case. Okay. Okay. So send me the picture, Dr. Yasser, to share.
For examination, will take permission from for examination. After wash my hand, I will try to make the comfort for the child, and then I will would like to see for the wellness alertness of the child, and will check for his height, weight, and head circumference, and will look for any unusual features and in the surroundings for any sporty devices like oxygen cylinder or any nebulizer or a saturation probe. Anything is there? Any finding?
Nothing.
Okay, then I will start my examination from hands. We'll check for clubbings, peripheral cyanosis, and stigmata of infective endocarditis in the form of uh, Genvalians, ossular nodes, and splinter hemorrhages, and would like to check for the nails for any deformity, leuonychia, or hyper or hypoconvex nails, and would like to assess the check the capillary refill time and peripheral perfusion on the both arms. Is there any finding?
Yeah, pulses are poor, weak,
I did not check
and
this.
peripheries are cold.
Okay, cold peripheries. So then I will examine the pulse, assess rate, rhythm, volume, character, and palpate on both sides. Is there any delay in the pulses?
So describe, tell the volume character, doctor.
A volume, low volume, and character is normal.
Okay. Okay. Then I will raise the hands of the child up in the air to check for any collapsing pulses there or not.
No, no.
No. Okay. Then I will move to the eyes. Will check for any pallor, any jaundice, or anything in the eyes.
No, only mild pallor.
Okay. Then we'll move to mouth. Check for dental hygiene and any high arch palate, any deformity in the mouth, and also we'll check for any cyanosis.
No, dental hygiene is poor, and only 4 teeth are there, and there is coated tongue, and there is no cyanosis.
Tongue is what? Coated. Okay. Then I will examine in the neck for any scars, any visible pulsations are there or not.
There are visible pulsation in
Yes.
there are visible pulsation in the neck.
Visible pulsation in the neck is there. Okay, then move to the chest, expose the child by keeping the modesty of the child in mind, and will do the inspection. Is there any scar is in the chest, under the arms, or any visible pulsation or any chest deformity?
No.
I will count the respiratory rate and check for the child is in respiratory distress at the moment. Is there any finding?
No, no. Respiratory rate is 40 per minute, and there is no deformity. And my only there is left-sided chest is bulging.
Okay, then I will check for the placing my both hands. Will check for the apex. Where is the apex? Left side, right side?
Apex in the left side, in the 6th intercostal space, in the mid-axillary line.
Okay, then I will start. I would like to check the character of the apex.
Character is no high character pulse.
This is a forceful, heaving character.
No, no.
No. Okay. Then I will start my palpation by putting my hands on the all areas of the heart, apical area, 4th intercostal space on the left side, on the 2nd intercostal space on the left side, and the 2nd intercostal space on the right side, and the suprasternal area and the carotid area. Is there any thrill?
Yeah, in the right upper sternal area there is a thrill.
Okay, then I will check for placing my heel of the hands. Is there any parasternal heave on the lower sternal border of the left side? No. Okay, then I will check, do the auscultation in the all heart areas, apical area, 4th left intercostal, pulmonary area, aortic area. Yes. If I'm looking for the 1st and 2nd heart sound and any murmur.
First heart sound is loud, and 2nd heart sound is normal, and there is a murmur in the right upper sternal border.
2nd heart sound normal and the 1st heart sound loud. Right upper sternal.
border.
murmur.
Yeah,
So I
murmur in
would
the
like to check this is character of the murmur.
character is
Finish,
blowing.
you can continue. Okay.
Okay. Okay, then what is the character of the murmur?
Is blowing.
Okay. Then I will check. Is it radiating to anywhere?
To the neck.
To the neck. So apart from this murmur, is there any murmur? I
No,
can
no.
appreciate. Okay, then I will check the check on the back in the between the scapula. Is this murmur is radiating to there or not? And also will check for the scars and deformity swelling is there on the back or not.
Back is normal.
Okay, I will assess for the lung basis for any coarse crepitations.
Yeah. There are fine crepitations.
Fine crepitations are there. Okay, then I will check for the liver is palpable or not.
Palpable. 2 centimeter.
2 centimeter. Okay, then I will check for the pedal edema as well.
No.
Okay, so in order to complete my examination, we'll check for the blood pressure, all 4 limbs blood pressure and saturation. In the room here, would like to plot his height and weight in the growth chart and would like to check for blood pressure as well and the femoral area for any scar is there or not, and
No
JVP.
scar. No scar.
So, okay, so
No JVP.
today I examine. Yes.
No JVP for 9 months. Proceed. Continue. Okay.
Okay. So today I have examined what was the name? A 9-month-old baby. He's well looking and appropriate for his age. Appropriate in height and weight for his age, and there is no clubbing or cyanosis, and uh, pulse is weak. Pulses is weak, but there is no radial or radiofemoral delay. And on the examination of the chest, on the examination of the mouth, there were 4 teeth on and poor dental hygiene, but there is no cyanosis. On the inspection of the chest, there was a bulging of the left side, and the apex is in the 6th intercostal space in the mid axillary line, and the child is having thrill on the right upper side, and there is right sided there is murmur, that is 4/6 murmur, and it is radiating to the carotid. First heart sound is loud, second heart sound is normal, and there is liver 2 centimeter below the right costal margin. So putting all together, I will keep my what will be the differential? I will keep the differential diagnosis first, aortic stenosis. The second one I will keep, though it may be less likely, hypertrophic obstructive cardiomyopathy, but that will be the less likely. And I will keep also the hypoplastic left heart syndrome also, but that can be less likely.
Okay. So what are the complications you have observed in this child?
So child is, which I am thinking the complications of right ventricular hypertrophy, and child is maybe in, we can say in failure, because the liver is 2 centimeters. आपने बताया था कितना? 2 centimeters.
Yes.
So, yes.
Okay.
Yes.
Continue.
So left ventricular hypertrophy, I can appreciate, because there was a bulging on the left side, and the apex is displaced to the mid axillary line and 6th intercostal space. So that may be of due to left ventricular hypertrophy as well.
Okay. Is the child is in failure or not?
Clearly, I cannot said, because the child was not having any respiratory distress at the moment. That was 40 per minute. So this is up to the mark, and there was liver is just 2 centimeter, and there is no pedal edema. So liver 2 centimeter, that can be like in failure, because the but sometimes it can be a normal.
What about the finding in the chest?
Yes, there were fine crepitations, so we will keep in the child is in failure also. वो मैंने नीचे लिखा हुआ है. Sorry. Yes,
Why
so
you
child
think?
is in failure. Yes,
Okay,
yes,
okay, no problem. Why
yes,
you
yes.
think that the left side of the chest is bulging?
I don't know. I don't think so. This may be due to left ventricular failure, left ventricular hypertrophy.
No. Sorry, I was forgot. There is pulmonary hypertension that causing the only reason that causing this left. But I forgot. I confused regarding the S2 finding. S2 should be loud in pulmonary hypertension.
Yes, you did not give me. That's why I was not thinking.
Yeah. That's my mistake.
One
But
more thing you have given me visible pulsation. I don't know. This one is coming in aortic regurgitation usually, not in aortic stenosis.
no. I cold and low volume pulses.
No. You give me in the neck visible pulsation, which I have written here.
Yeah, in
Okay.
stenosis.
I was thinking the thrill because in aortic stenosis we feel the thrill.
Yeah,
So
that one we are feeling. We are not looking. So that was inspection. That was I was confusing. This one is going to the pulmonary hypertension or AR. What? Okay.
Yeah. Okay, because the thrill is also look like a with pulsation.
Thrill. We are palpating. We are not.
And when we put our finger, we feel.
Yeah,
Like,
feel. We thrill is like voice. Thrill is voice.
Yeah. Okay.
Yeah, this is the voice which we are feeling. We are not listening the thrill. We are feeling the thrill actually.
Yeah. We palpate and then we can find. Okay, no problem. Okay, how can you investigate your case?
So for investigation, we'll have to go for ECG, and where we can see the left ventricular hypertrophy. RV will be taller in the V5 and V6 area, and there may be deep S wave in one AVF and V1 and V2. So this is the ECG. We can do the chest X-ray. Again, there will be the left ventricular will be prominent in the chest X-ray. Yes, that's then we can final diagnosis should be by echocardiography.
Sorry, doctor. There is inverted T waves in one AVL and Y5 and
Yeah,
V6.
inverted T wave. Sorry, T wave. Not
T
wave.
wave. Yeah.
T wave. Yes.
Okay. How can you? What are the association of aortic stenosis?
Aortic stenosis, they may have with some syndromes like Noonan syndrome. Sorry. Turner syndrome. They may have with the Williams syndrome. They may have with the coarctation of aorta. They may have with the Hockham hypertrophic obstructive cardiomyopathy. They may have association with hypoplastic left heart syndrome. So these are our association with the aortic stenosis.
Okay. How can you manage this case?
So for this management, as the child is in failure, so we will have to educate the parents about the diagnosis, and definitely we will have to involve multidisciplinary team in the form of pediatrician, and we will have to involve our consultant and the cardiologist and the dietitian. As the child is in failure, so may he need some medicine that will be prescribed by the cardiologist. There may be given some diuretics and good advise the parent for the good dental hygiene. Anti-failure treatment that can be considered AC inhibitors, diuretics, and good diet here should be given. Though the child is appropriate for his age, but he's in failure, so it may affect his growth as well. So dietitian should be involved for the high caloric diet, and again should be considered for definitive if the child is having this after confirming my diagnosis. After the confirmation of the diagnosis by the echo, should we go for the definitive either child needs balloon valvoplasty or the corrective surgery.
Okay, okay, good. But only your differentials are not up to date. Others are okay.
What should be the differential here?
VSD.
I don't think so.
Yeah.
VSD murmur will be. I don't think
I know,
so.
but this hypoplastic left heart syndrome and these others, they are very difficult to.
Yeah,
And
very
child is
difficult.
9 month old.
Actually, you have given me the 9-month-old, and left-sided too much bulging is there. So that's why I was thinking this is left-sided bulging, and the displacement in the VSD there will be not displacement, because
But in
the
hypoplastic left heart syndrome also there is no dysplastic.
No, in the hypoplastic left heart syndrome, there sometimes there may be displacement. There are sometimes dilatation can be there too much. But in hypertrophic obstructive cardiomyopathy, that can be keep in mind. But in VSD, I was thinking VSD also. But in the VSD, if the child is 9-month-old, and if even it is too much big VSD, then even not will come this apex will not be displaced too much. I don't think so. If this is reversal is there, then child will be cyanosed. So that's why this was confusing me actually.
Okay, no
So
problem,
that's
because
why.
I have one book here. It is written VSD, PS,
Yeah,
AS,
VSD can
and
be.
MR.
MR can be think. Yes, that can be think of.
Okay, wait. I am now confused with your conversation. While telling the murmur, he said blowing. I think this was a wrong cue given, right? He should say ejection systolic if it is aortic stenosis.
Yes.
Blowing is for aortic regurgitation. This was one thing which confused me. Another thing is, now just tell me what was the positive findings in this child. Only positive findings.
Only positive finding was
in aortic stenosis we will not have visible pulsations in the neck, right?
Yes, that's I written here. I don't know, he has given me, so I was confusing, that's why.
Okay, leave. Tell me now, if this is an aortic stenosis case, what would be the correct, because in the exam we will get the correct cues. Okay, so let's go with that cues. So tell me what are your findings?
We will do like this. This is the aortic stenosis and it is not corrected yet. Okay, they have not done anything. So then will be the what will be the this positive finding. Start from the hand. Okay. Usually, because usually these peoples are asymptomatic, so I will not keep, they are short, or they may be short, but start from the hand. Okay, start from the hand. There will be no clubbing, no cyanosis, nothing will be there. But as Dr. Yasir told, there can be cool peripheries. This is the first positive finding. Cool peripheries can be there. So you will have to ask.
Then second,
we are checking the pulse. So pulse can be low volume pulse, weak pulse, or like this. Okay, weak pulse you can write. Low
as
volume.
we say, weak thready pulse is described like this, right?
Yeah, thready pulse is like coming in if the child is in shock.
Severe.
So yeah, severe. But in aortic stenosis
or in shock.
Yeah, in shock. But in simple aortic stenosis, there is no symptomatic they have not done anything. So weak pulses will be there. Okay. Then we are coming to the blood pressure. Okay. Blood pressure can be sometimes higher. It depends where is the lesion, valvular, subvalvular, or supravalvular. If the supravalvular is there, so blood pressure sometimes may be higher.
Okay.
So
otherwise,
this will be higher.
Otherwise, it will be normal or low.
It will be higher on the right side than the left side. There can be discrepancy a little bit in supravalvular.
Same like in like coarctation.
Yeah, because it is coming, it's going supravalvular. So it is not the level of valve. It is like the behind the, yeah. So that's why I'm saying that there can be some discrepancy of blood pressure on the right and left side. And then then we will go to the eyes. So there will be no problem in the eyes. Then we will go to the mouth. So mouth, again, we'll have to check poor dental hygiene or something like this. So regarding aortic stenosis, there will be nothing. Like if they have some problems with the syndromic, I will not go that. Okay. Then we are coming to the chest. So in the inspection,
neck, nothing. Neck also.
Yeah,
nothing.
neck will be nothing. Neck will be nothing.
Okay.
Okay.
Chest. Okay.
And in the chest, now we are coming to the chest. So there will be on the inspection, there will be nothing will be there except like Dr. Yasir has given me the case. So this was a severe, maybe that's why he's having this failure signs. So we are going for normal. So their inspection will be nothing. But on the palpation, there can be thrill. So thrill, where will be the aortic thrill will be where?
Right upper sternal edge.
Yes.
Either in right upper sternal edge or in the left lower sternal edge.
No.
No. I will tell you, there can be a thrill on the right upper sternal edge. Okay. Second intercostal space, I mean say. Then there can be carotid thrill. There can be suprasternal thrill. These are three areas. Okay. Three areas can be thrill, like in suprasternal, carotid, and thrill over the aortic area. So that aortic area is upper right sternal edge or second intercostal space. Okay. Then you will check for the apex. First you will check apex, then you thrill. Okay, we have done thrill. You will check for the apex. So apex always ask, if you are thinking this is aortic stenosis, always ask for the character. So the character is coming for forceful or not forceful. If it is forceful, yes, this is forceful. Then it is coming, this is sustained or not. No sustained or sustained. If sustained, that's mean this is heaving. And heaving pulse is coming in aortic stenosis.
Okay.
Just to memorize.
Heaving apex.
Yeah, so heaving apex is aortic stenosis. Okay.
Okay.
And non-heaving apex is coming in aortic regurgitation usually. If they will ask you. And forceful apex but not sustained, then it is coming in mitral stenosis, I think. I will have to check. Yeah, in mitral stenosis. So here you will check for the apex. So our apex can be forceful, sustained, heaving apex. Then you will do the auscultation. On auscultation, there will be a murmur. So what kind of murmur? Ejection systolic murmur. Ejection systolic murmur will be where? Second, upper right intercostal space. Okay. And we are checking for heart sound, S1 and S2. S1 will be normal. S2, again, we have two components, aortic component and pulmonary. So aortic component will be little bit quite soft, anything can be there. Okay. And sometimes you can check for the click also. In click can be there, ejection click. That is again will be the upper sternal edge. They have written left sternal edge and apex. I don't know why they have written. I'm not getting this one. This is some misunderstanding.
Okay, no problem.
In the book.
Okay, it is. I know that this is aortic area. There is something written. Even I saw that. Okay, next.
So this is our normal case. And if now we are going to the second case, they have corrected.
No,
they have corrected.
Okay, you will tell about heart failure in the case like Dr. Yasser presented.
Yeah. So in the last you will tell that the child is in the failure as well. The finding is the displacement of the apex on the mid axillary line, 6th intercostal space, and there was fine crepitations, and there was liver 2 centimeter below the right costal margin. So I think the child is in failure also.
Okay. Apart from that, I want to ask you what this, see, mid clavicular line, then we have three lines: anterior axillary line, mid axillary line, and posterior axillary line, right?
Yes.
Mid axillary
Yes.
line means it's too much big heart.
Yeah, very big heart. That's that is
Anterior
that's why I was
axillary
thinking
is okay considered.
why liver is only 2 centimeter, because in children's, in infants, we are taking 2 centimeter almost normal, but this is apex is going beyond this. So
Actually,
that's
you
why I
have to
was
ask
confused.
either the liver is tender or non-tender.
Yeah, that I know. I was thinking I should ask, but I did not ask.
Yeah,
Because
this is the only differentiated point between both of them.
yeah, in
Either this is
failure there will be
physiological
tender.
or this is the
Pathological. Yeah, very good.
Yeah, always remember, if there is tender liver, so this is from the cardiac. Yeah.
Yeah. Tender hepatomegaly is important. Yes.
Either infection or either this one.
Okay. Now we will go for operated case and then we will come for heart failure. Okay. So I'll tell about operated case now.
Okay, just 1 minute. Operated case can be like a balloon, or either can be corrective surgery. So again, we will start from the hand. In the hand, we will not find anything. Okay.
Okay.
No clubbing will be there, no cyanosis will be there, but again there can be cool peripheries. Okay. This is the one thing. Then we will go for the pulses. Again, in the pulse, there can be weak pulses or there can be collapsing pulse. Why I'm saying the collapsing pulse? Because in the incompetence can be there. So there will be collapsing pulse or there will be weak pulse. So these are the two things. Again, then we will go to the eyes, there will be nothing. Then we will go to the mouth, there will be nothing regarding this, that. Then we will go to the neck. So neck, you can find, if there is incompetence is there, you can find a Corrigan sign, that is the dancing carotid or visible pulsation. I have seen this one.
Okay, it is called dancing carotid or visible pulsation of the carotid.
Yeah, visible pulsation will be there, or dancing carotid, or name is Corrigan sign.
Corrigan sign.
Okay. After that.
Then, yeah, then you will go to the. What is this? Somebody sending me message. Oh, okay. Then we will go to the chest. Sorry. So in the chest, what we can see in the chest? Again, this is corrected. So very less likely we will find on inspection anything. Yes, Dr. Yasser, am I right?
We can see the apex beating, right? Sometimes.
Sometimes we can see if there is like Dr. Yasser has given the case.
Okay, forceful, sustained heaving apex. Sometimes we can see.
Simple, you can say well sustained heave or ill sustained heave.
Yes,
if you put your finger and you feel your finger is continuous, is up moving, and then this is well sustained. If it is just, it is saying just like somebody is knocking at your door and you feel that sound, that is well sustained. Continuous.
Well sustained is coming. Well sustained is coming in aortic stenosis. Ill sustained, which I remember, I have to see, which I remember by, I think this was aortic regurgitation. This is hyperdynamic actually. Hyperdynamic. Yeah. So this will be aortic regurgitation, I think.
Okay, very good. Okay, next, continue.
Then
chest.
Then we will, yeah. Then we will go for the palpation again. So palpation, there can be thrill for on the aortic area.
Apex first. Apex again. Say.
Apex again. I will tell you. There can be well sustained apex.
Right. This is corrected.
Yeah. Apex can be displaced, cannot be displaced. Both can be there.
Okay. If there is no hypertrophy, no displacement. That's all.
Yeah.
If it is hypertrophy, can be displaced. Okay.
Yes. So then we will go for the thrill. So in the thrill, there can be thrill on the aortic area, suprasternal, again the carotid area. Okay. Then we will go for the murmurs. So if it is corrected, if it is simple aortic stenosis, but there is no incompetence, so there will be murmur only the same areas.
Okay.
like we have done before. If
Yeah.
there is incompetence is there, then there will be another murmur that will be of mid diastolic murmur or early diastolic murmur, that will be in the third left intercostal space.
Okay. Third left intercostal space. Okay.
Yeah,
Yeah.
third or fourth.
Oh, so it is like we can otherwise we can also say left lower sternal edge.
Yes, left lower sternal edge we can say, no problem.
Same like the tricuspid area or left third intercostal space. Anything, no problem.
Yes, this is usually most of the time early diastolic murmur, because there is incompetence is there. So as the blood is pushing out, some blood will come back. So this will give the murmur. So early diastolic. Sometimes it is mid diastolic murmur can be there, because it's because when the heart is pump out, so systole finish, diastole started. So if the blood is coming, blood is coming back or water is coming back, so it will give some noise. So it can be early or it can be middle. Late will not be there.
Okay, so okay, then after murmurs, the radiation of murmurs now for aortic, where we check neck.
Yeah, aortic. If there is if there is stenosis, again the murmur will be radiate to the neck in the carotid area or suprasternal area.
If
Okay.
regurgitation,
If regurgitation, then we will have to check the murmur. But again, here child was 9 months old, so I cannot check with the respiration. But we should check with the respiration. If the child is old enough, we should check with the respiration as well. So in that one, I will have to see. Till now, I was just telling by my mind, but sorry.
what is your doubt? I will tell you. Tell me.
In AR, there is murmur on the change murmur with sitting position. I remember which one.
AR or all
leaning
right-sided
forward and on
murmurs?
expiration.
Sorry.
Leaning forward and on expiration.
Wait, I will tell you. All left-sided murmurs, that is both aortic stenosis and aortic regurgitation, they become louder by leaning forward and on expiration.
Yes.
We can remember the mnemonic here, LE. LE means left-sided murmurs will become louder on expiration.
Okay.
LE. So yes, you will check this. You will ask him to bend forward and sit and put your stethoscope both on the aortic area and the second aortic area.
Okay. Which I was forgetting.
Yeah, and it will become louder on expiration and also by the position, the leaning forward position. Okay, and I think the AR murmur, because here what happens, this is the aorta, right? You are seeing my drawing, I guess. So it will come back like this. So there is a chance that the murmur will radiate to apex. This is how I remember. If I am right, just tell me. Right? Because the blood is flowing back like this. It is there is incompetency. So whenever there is diastole, the blood is coming back like this. There can be radiation to the apex. This is my thinking. If I am wrong, just tell me.
No, you are right, because all the vascular murmurs, they are radiating.
So the radiation of aortic stenosis murmur will be to the neck. Aortic regurgitation will be to the apex. Okay. Or the
aortic regurgitation will be where?
As I have drawn here, like this, to the mitral area. But we can go back and check, no problem. This is my concept I am telling you, because the blood is flowing like that. In ejection systolic, what happens? The blood will gush here, right? And it will go to the carotids like this. It will also gush into the carotids. This is the reason you are listening there. You are feeling the thrill and the radiation there. In here, it is coming back like this. So you should hear in the mitral area. Okay.
Okay.
No problem. We will check and we will send in the group. Next, then what happened? We came till the murmurs and radiation and thrills, I think. Next, then.
Okay, then we will have to see. We have done this auscultation.
Hmm.
Then we will have to see for lung basis also if the child is in failure or not, and the liver also. Bas this one
And edema.
edema. Yes.
Then in order to complete, same forelimb
Yeah.
beep, forelimb oxygen saturation, humeral scars, JVP if
They
more
are
than
piston
2
short
years.
murmurs.
JVP if more than 2 years.
In short, Dr. Yasser, if you are going for this exam, never ever say these things. Even they don't know, and they are bothering this one.
What,
Okay, okay.
what?
Because there are a lot of signs of in the Corrigan. I forgot the exact names. There are 5-6 signs of these aortic
Okay,
regurgitation.
wait. Next, we will go for the now. If the child is in failure, as the now which Dr. Yasser presented is aortic stenosis with cardiac failure, right? This child
Yeah,
has
yeah.
a big heart. We will keep it as anterior axillary line. Okay, sixth intercostal. When the examiner says sixth intercostal space, immediately we have to think that there is enlargement, because normal is fourth and fifth only, right? Sixth
Yeah,
is
yeah.
the enlargement, and they can also say up to anterior axillary line, or they can also say sixth intercostal space lateral to mid clavicular line. They can say just like this also. Okay, if they say sixth intercostal space lateral to mid clavicular line, khalas, we got to know that the heart is enlarged. Now, depending upon the character of the apex, whether it is forceful and sustained, you will get to know whether this is left ventricular hypertrophy due to aortic stenosis or HOCM, can have forceful and sustained, right?
Yeah, yeah.
And unsustained is in, as you said, aortic.
MR and IR. AR. MR and AR.
MR and AR. Okay. Regurgitations usually.
Yeah, yeah, yeah.
So for well sustained, it can be aortic stenosis, HOCM. Any more examples?
This left ventricular hypertrophy.
Yeah.
Okay, finish. That's it, right? Then we will go for the management. I will ask some questions for Dr. Adnan. If Dr. Yasser is done with his questions. You have any questions, Dr. Yasser?
No, no, no. He's fine.
Okay, now you will tell us about the management for this child.
So for the management, as the child is in failure, first of all, I would like to involve cardiologist, my consultant, and dietitian again. And for failure, we will have to start the medications that can be anti-failure medications, AC inhibitors or diuretics, but it will be dependent on the cardiologist choice.
Okay.
And again dietitian, because these childs may need high caloric diet, so the dietitian will be play a good role here also.
Okay.
And
Next, tell about the management for the valve. What do you, this is still not operated case, right? So, and the child is symptomatic. So how do you want to proceed for investigations and management?
investigation, I told already that we'll have to do the.
So when the aortic stenosis, this question was asked. Tell about the means by echocardiography, how do you know whether it is mild, moderate, severe in aortic stenosis?
Yes, we will have to check the gradient. Again, here is the mild, moderate, and severe gradient is same like pulmonary stenosis.
No, there is change. There is change. I will.
There is change.
Yeah, there is change in aortic stenosis, not same like pulmonary stenosis. Okay, what is the indication for, what are the indications, not only in this child, generally tell me, what are the indications for surgery or balloon valvuloplasty in aortic stenosis, indications?
Indication for surgery or balloon valvoplasty if the gradient across the valve is more than 60 or the child is symptomatic.
Okay, so it's symptomatic or more than 60.
Yes.
No problem. Then what else? What advice you want to give to the parents?
For the parents, advice is first of all, follow up with the cardiologist, compliance to the treatment, And the third one is avoid some heavy sports.
Okay, avoid strenuous sports or
So,
heavy
yeah,
exercise.
strenuous or heavy sports or gym-like sports,
Okay.
gyms.
Anything else?
And what else?
Okay, some common advice for all CVS cases involving the valves will be to maintain good dental hygiene.
Yeah, good dental hygiene. Yeah, forgot.
Remember, this is common for all. Any
Yes.
valvular case which has an what do we say, risk
In the
factor for infective endocarditis.
yeah, in my previous I told Dr. Yasser, no, forgot.
Okay, no problem. So what advice you give to the parents? First thing is avoid heavy exertion exercises, good
Yes,
dental hygiene. Okay.
yes,
And this is very important. And what, as you said, the compliance of the medication also.
yes.
Then for this, I want to ask you, there is now in the recent management, you know about this transcatheter aortic valve implantation.
Yeah, they are doing this implantation, but I don't know too much about that.
No need to know too much, but at least we should know this to answer. I am telling you. Suppose if they ask you about the management, what happens in the balloon valvuloplasty in aortic stenosis is they have written that there is chance of restenosis in 6 to 12 months. You do
Yes,
balloon valvuloplasty and there is restenosis again in 6 to 12 months. So it may not help you much. So you have to
yes,
go for definitive. That will be transcatheter aortic valve implantation or aortic
yes,
valve replacement by surgical repair. Now, mostly they are preferring this because you will not do open heart surgery here. You will do by
yes,
catheterization, cardiac catheterization. Okay. So you should know at least this name. That is transcatheter aortic valve implantation. Aortic valve implantation.
okay.
Okay. So what are the complications for aortic stenosis?
Aortic stenosis complications. They may have problems with the heart complications can be there, like infective endocarditis, as this valve is involvement of the valve. So we should kept in infective endocarditis. We should kept this can leads to the left ventricular hypertrophy. So that will again child may be in failure, heart failure complications can be there. And what else?
Failure to thrive, pulmonary
Failure,
hypertension.
failure to thrive can be there. They can lead to the pulmonary hypertension as well.
And recurrent chest infection because the lungs are wet. So
Yeah, because the as you said before, through the aorta the blood is not going. So what happens? It will start going back. So the backflow will be for the lungs, right?
Yeah.
So indirectly later there will be right heart failure as well.
There can be pulmonary hypertension, there can be failure, but failure is coming here at the end, you can say last.
So the main common complications for
actually scenario should be age of the child, just like 9-year-old. Sorry, because this is the
Yes.
pulmonary stenosis. These children should be just like 9-10, student of 3-4, just like this one. So here there we can explain everything in very good way.
Yeah, and the gradient you should know across you should know the mild, moderate, severe. If Dr. Yasser knows the gradients for aortic valve.
No, sorry, I did not go through the gradient.
You have to, because they asked this question to the candidate when she said echo. They told her tell how, when do you say it is mild, when do you say moderate, and tell the gradients. like this. And also the question was asked indication for yes, I will share you the photo. So Dr. Okay, Dr. Adnan, if you want to go, you can go. Only see this clip and go only 1 minute.
Okay.
Yeah, this is what I was telling you for the aortic stenosis. Here you see for the aortic stenosis, mild is less than 20. Moderate is, we can keep it as less than 20, 20 to 40, 40 to 60, and more than 60. Okay.
Okay.
So again, same like in pulmonary stenosis, what we said, if the patient is symptomatic, even if he is less than 60, you will go for intervention like balloon valvuloplasty or the second, what I said, transcatheter aortic valve implantation or transcatheter aortic valve replacement. Tell this before the surgical procedure because now this is coming up. Okay, just the name we should know. Because
Okay.
this can be done by the cardiac catheterization through the femoral area. Okay. So this is the important point we have to tell apart from balloon valvuloplasty. Why they are going, the indications here is because in balloon valvuloplasty there is more chance of restenosis. Okay, and occurs with this stenosis can occur in 6 to 12 months. Another reason is some are not fit for surgery. Some children may be not fit for surgery. So in such cases, this transcatheter aortic valve implantation is helpful. One more important point here is this balloon valvuloplasty, it will be done as palliative sometimes. Like the child is small, you want to give him time to grow to go for this replacement of the valve.
Okay.
Okay, this is like as a treatment as well as a palliative, because you know that there is a chance that restenosis can happen and you have to go for aortic stenosis. I mean, you have to go for transcatheter aortic valve implantation, but you are giving time for the child to grow. So this is one of where you will consider balloon valvuloplasty. These 2 points you have to remember. The risk is restenosis and regurgitation with this balloon valvuloplasty. So you may have to, and another, as the child grows, there also can be calcification in the aortic valve, right?
Yes.
So the valve may not function. Even if you do balloon valvuloplasty, at one point of time, you have to go for some procedure. So the next preferred procedure will be this. Before telling the open surgery, let's remember this transcatheter aortic valve implantation. And the gradients here is, we will start with less than 20. Okay, less than 20 is mild, moderate is 20 to 40, severe is 40 to 60, more than 60 is severe. Okay, even if the child is asymptomatic, more than 60 you will go. If symptomatic, even if less than 60, you have to intervene. That's all we have to remember. Okay.
Okay.
Is that clear? Okay.
Yes.
Okay, you can.
Okay. Tomorrow we will do.
Tomorrow I will see. I am just trying to cover the previous exam scenarios only we are covering now. But I think we have to cover more. I am thinking at least one case more, right?
Yes.
Because
Yes.
otherwise
Yes.
we will lag behind.
Yes.
I
We
will
should
message
cover
you.
all.
I will message you. And if I am candidate also, I will message you beforehand so that you will not give me picture and any cues. Okay.
Okay. Okay.
Today, what happened? If Rehana was there, I would have taken Yasser's case and given her. She is not there. So the something wrong went. Okay.
Okay. Okay. No
Okay.
problem.
Thank you.
Okay, inshallah, see you tomorrow.
Okay, Dr. Yasser, can you tell me about your case? What had you exactly prepared for him? Because I wanted to know.
You messaged me regarding Noonan syndrome. I prepared Noonan syndrome.
Yeah, because something here. Wait, I will pause 1 minute. And
The case of
okay, go ahead.
yeah, it's a case of simple pulmonary stenosis. But they ask we have to find other. We have to ask other features of this Noonan syndrome because it's associated with this one in the examination only.
Okay, then.
And then accordingly the finding is there, and we have to see the other stigmata of other infective endocarditis, and also to see other stigmata of heart failure. And
Okay.
other third thing is cyanosis. We have to see cyanosis because when there is critical pulmonary stenosis, there is cyanosis. So these are the three parameter we have to see in the patient. And then we have to tell about the syndromes associated with pulmonary stenosis, as Dr. Ruhail informed us. That's William and this Noonan
and
and
Alec.
the Alagel syndrome also.
Anything else?
No, nothing, only.
So a child like this, I have to also look for the unusual features related to these syndromes. This is one thing. Another thing, because it is critical, if it is pulmonary stenosis, maybe critical, we may expect cyanosis. And also stigmata of infective endocarditis. So I will check for that. And so I will feel for the thrills and the scars. And on my examination, there is only ejection systolic murmur in the pulmonary area and an ejection click. So it will not be innocent because there is an ejection click here.
And thrill also palpable. Yeah. The click is there. You are right.
Okay. Thrill is not written. I think he hasn't written anything.
Yeah, that is not.
You cannot see any. Sometimes they cannot. If thrill is not there, you can put it as 3. But there are other features like ejection click and the murmur. This is okay. I have one question for you. How the pulmonary murmurs? How you check for pulmonary murmurs? Like for aortic murmurs, you said leaning forward and on expiration. For pulmonary murmurs,
On the same, laying down, and if we ask the child if he is cooperative, hold the breath on inspiration, and we can check the intensity of the murmur. If
okay.
it
What
is
about even this pulmonary also in sitting forward leaning or no?
no, only for there are only for AR we are doing this one. Even not for aortic stenosis, we are not doing this one because they are the diastolic murmur, and diastolic murmur only heard by the bell.
So how we will remember which is for the bell and which is for the this?
Only two murmur, MS and AR.
To listen only 2 murmurs by the bell, AR and
Because
MS
they are
and
diastolic
RAHMAN.
murmur. They are diastolic murmur, and diastolic murmurs are best heard by the bell, not by the diaphragm.
So I will remember only 2 murmurs. I have to use bell. That is diastolic murmurs. One is the mid diastolic murmur of mitral stenosis and early diastolic murmur of aortic regurgitation. Is that right?
Yes.
Okay.
Just for memorizing and just to become confused, and then we don't be confused. We starting from the aortic area by the bell. Just we make a Z. When we reach the aortic area, we just turn and then we can proceed so that we cannot forget.
Okay. I did not get you. What is the Z you are telling?
N means mitral. Then we can get the tricuspid area. Then we go to the aortic area. Then we pulmonary area, and then we can go to the aortic area too.
Okay, like this. You start with mitral area, then I will auscultate tricuspid area. Then I will auscultate this is right side and this is left side. So then I will auscultate the pulmonary area. Then I will go to the aortic area, all with the diaphragm. Where if I have to auscultate here, that is the second aortic area, I will use the Bell.
Bell.
Okay. And also if I suspect mitral stenosis, I will use the bell.
Yes.
Okay. And let's talk about the radiation of murmurs. So the aortic stenosis will radiate to the neck. Okay.
Yeah.
Pulmonary stenosis to the back. Then
Yes.
mitral regurgitation to axilla. Mitral
Yes.
regurgitation and stenosis both to axilla, I guess, right?
Only there is, I think so, there is radiation with the mitral regurgitation, not with stenosis.
Okay, let's see that. Okay, let's see, and you message me if you get the answer. Means maybe you are right. Let's recheck and
We
confirm.
will check. We will reconfirm, no problem.
Stenosis, pulmonary stenosis, mitral regurgitation. Then what else? Tricuspid regurgitation or stenosis. And this is very rare in exam.
PR is there, TS is unlikely. Never come, never listen.
Okay, TR you can I can see with aortic stenosis sometimes.
Even with the TOF, we can see TR.
Okay, the same reason.
Yeah.
Okay. So okay, no problem. So
Just
tomorrow,
like this Eisenmenger, and also with this one the PPH, we get TR murmur.
Okay. Okay. So now from today, what I will do, I will put 4 cases, and I will assign role players, but I will not assign the candidate. Anyone should be ready to take any case. Okay. Is
Yeah,
that
yeah.
okay?
Everyone perform one case, and who's the one? I mean, first one can perform, and then succeedingly we can proceed.
Okay, even if we cannot finish the case today, we can do it next day, no problem. But let's not confine, otherwise there will be some confusion like this. Okay.
Yes, yes.
But one question I wanted to ask you, but please check also. I wanted to ask Rohel also. This management of supravalvular aortic stenosis, what is it? I mean, the valve is okay. So what they do usually?
They are doing surgery.
Surgery, are they using this balloon dilatation with stent or no? Like for example, this is the heart. Now what happens here is the aorta is okay in the beginning. There is stenosis here. There is stenosis and then there can be dilatation. The valve is here. The valve is good. So they will use balloon here or not? This is my doubt, with stenting or something. I don't know really.
1 second. 1 second. I will answer you. Give me 1 second.